Hello, namaste students. Today we will be discussing about one very interesting central nervous system case which is very important for postgraduate students as well as undergraduate students. Okay. So, let us see what is that interesting case. So, today the date of presentation is 14th February 2021. Okay, I am presenting today this case. Okay, but the patient history was taken on December 9th 2020. December 9th 2020. Okay, so on that day when she came December 9 2020, what was the complaint I will present and how she progressed over the last 2 months also I will discuss in detail. So, the patient by name is X 70-year-old female. She is not educated. She is a housewife from Bangalore. History given by son and it seems to be reliable. Chief complaints: difficulty in getting up from squatting position since 11th day. Difficulty in lifting the hands and do activities since 10 days. No hands or leg movements since 9 days. So, you can see students within 2 days the weakness progressed from everywhere from lower limb to the upper limb. I repeat the chief complaints: difficulty in getting up from squatting position since 11 days, difficulty in lifting the hands or do activities since 10 days, no hand or leg movement since 7 days. This was the history when it was taken on 9th 12 2020, the December 9th 2020. Okay. Coming to the history of presenting complaint, the patient was apparently normal 11 days back when she developed difficulty in getting up from squatting position one fine morning. It was sudden in onset, gradually progressive. Next day she was not able to hold chappals on the leg and she had a mild difficulty in lifting right upper arm. By the next day the weakness progressed to the left upper limb also, and then she was not able to lift both the hands and not able to mix foods or wear cloths on her own. So, upper limb, both the hands, she couldn't, the distal muscle weakness, she couldn't mix the food or button or unbutton the cloths or cannot lift the hand above the head. Lower limb, both the lower limbs was affected. Okay, she couldn't get up from the squatting position, which indicates a proximal muscle weakness. She couldn't hold the chappals, which indicates a distal muscle weakness. So, patient was not able to mix the food or wear the cloths on her own. There was absolutely no movements of both the legs then, and then she became bedridden. Okay. So, the motor weakness progressed and absolutely she was bedridden, she couldn't lift both the legs. The weakness whatever she had, there was no diurnal variation of the symptoms. It was persistent. The weakness whatever she had, it was a sudden onset, developed over hours to days, and then it was persistent. There was no diurnal variation. The test is important to rule out neuromuscular junction disorder. Of course, this is not the age to develop 70 years, it has a bimodal peak 20 to 30 and 50 to 60, she is 70-year-old. No history of any memory deficits or difficulty in speaking. She could speak, there was no difficulty in speaking and her memory higher mental function was normal. There was no change in voice or difficulty in swallowing, nasal regurgitation or dysphagia. So, symptoms suggestive of lower cranial involvement was not there, no nasal regurgitation, no hoarseness, no dysphagia, it was not involved. And also there was no any deviation of the angle of the mouth to any one side, there was no facial involvement also. No difficulty in vision or hearing. And coming to the sensory symptoms, she could appreciate the cloth on her body. Okay, the cloth on her body she could appreciate, which indicates the fine touch, which carried by posterior column. She could feel the hot and cold water sensation whenever she used to take the bath. So, even the pain and temperature fibers are also normal. She could feel the hot and cold water sensation whenever she takes a bath. So, no sensory symptoms at all. Okay, sensory symptoms is not there. It is normal, history wise, symptom wise. And whenever she had that weakness of both the lower limbs and the upper limbs, there was no fever at that time. Whenever she developed the weakness, no fever was there. No bowel and bladder symptoms. Bowel and bladder was normal, she could appreciate the sensation, she could evacuate. Bowel is also normal, it is not affected. Very important student, these points are the key points. Bowel and bladder normal, sensory normal, because this will distinguish the anatomical localization in the CNS. No history of headache, loss of consciousness or involuntary movement of the body. No history of any trauma. So, because she developed both the upper limb, lower limb weakness, any traumatic dislocation of the spine, you have to thing. So, any history of trauma is also important. No history of any autonomic symptoms like fainting, giddiness, sweating, diarrhea or constipation. So, she is not giving any symptoms suggestive of autonomic nervous system. There is no history of any snake bite which can produce a neuroparalytic snake bite can produce a weakness like this. So, you have to ask that history of snake bite. No history of dog bite because vaccination they will take for a dog bite which can produce a motor weakness like this because of a acute inflammatory demyelinating polyneuropathy, polyradiculoneuropathy. So, that is where the history of any dog bite was asked. And insect bite, especially tick bite. A tick bite can produce a similar picture like this, a weakness of both upper limb and lower limb, a tick bite. So, that history is important. Or no history of ingestion of any unusual food materials, okay, especially shellfish. Shellfish poisoning can produce a motor weakness like this, upper limb and lower limb, one of the DD for acute inflammatory demyelinating polyradiculopathy or Guillain Barre Syndrome. So, no history of any unusual food intake and there is no history of any recent vaccination. Again this was asked, okay, because it can produce acute inflammatory demyelinating neuropathy or even transverse myelitis. She is having weakness of both upper limb and lower limb, hours to days progress, transverse myelitis can be vaccination can produce. So, that is why that history is important, vaccination history. No history of thorn prick, a buckthorn can produce a motor weakness like this upper limb and lower limb. So, a buckthorn history was asked, any thorn prick was there, was asked, it was not there in her. No history of any chest pain, breathlessness or palpitation. Coming to the past history, there is no history of similar complaint in the past. This is the first attack what as she has experienced the motor weakness of both the lower limb and upper limb. But one important history is she gives, there was history of fever 1 week prior to the onset of this motor weakness for 1 day. Very important history, students, you have to note down. 1 week prior to the onset of whatever she dealt with the motor weakness, she had a 1 day fever history plus associated with a loose motion which subsided by itself. After that episode of fever and loose motion, she developed the weakness. Okay, students, after the fever and loose motion, she developed the weakness. But when she developed the weakness, there was no fever. That is very important, students. So, fever and loose stools recovered spontaneously without any treatment. She is a known case of diabetes mellitus since 1.5 years and she is on oral hypoglycemic drugs. No history of hypertension, coronary artery disease or thyroid disorders. Family history, no history of similar complaints in the family. Personal history, takes vegetarian diet, bottom bladder habits are regular, habit of chewing betel nut since 2 years, she is married and having 4 children. Socioeconomic status, middle socioeconomic status. Okay, students. So, this is the history. Okay. Now, how you analyze or interpret the history here. She is having fairly symmetrical weakness of both the upper and lower limb and it is ascending initially in the lower limbs and then it came to the upper limb. No sensory symptoms, no bowel and bladder is involved. Now, where you want to localize? As I told students in the CNS, I told either you come from top to bottom or bottom to top. Any approach is justifiable. Let us go where to localize anatomically, where is the problem. Let us go from bottom to top, okay, for it is interesting. Whether she is having any muscle disease, a neuromuscular junction disorder, whether she is having, but neuromuscular junction disorder, they will have motor weakness like this accepted, no sensory, no bowel and bladder, but it will be a relapsing and remitting, relapsing and remitting. Can it be inflammatory myositis like dermatomyositis which we discussed last class? There the history will be, won't be acute like this within hours, the weakness won't be like this within hours and they will be associated with the muscle pain, inflammatory myositis. Can it be a muscle dystrophy? Very long history will be there, years. Here very acute onset this is, we cannot think only the muscle dystrophies like Duchenne's, Becker's, facioscapulohumeral. In this age group, oculopharyngeal muscular dystrophy, 70 year. Muscle dystrophies are very chronic. So, muscle, post muscle channelopathy is a hypokalemic periodic paralysis. Is it possible in a pure motor weakness, both upper limb and lower limb? Again, channelopathy is remitting and relapsing. This is the first attack, whatever she is having it. and usually some channelopathies will be precipitated by exercises, high carbohydrate intake, like the precipitating factor will be there. And here she says after the fever and loose motion she developed the motor weakness. So, channelopathy, neuromuscular junction disorder and muscle disease. Next is root, anterior root. Let me come to the anterior root little later, because probably she is fitting most probably into that. Can it be anterior horn disease? Pure motor anterior horn disease, which is a disease, students? Poliomyelitis. But poliomyelitis will be asymmetrical, comes predominantly in children's and older children's and adults, and the weakness in poliomyelitis will develop at the peak of the fever. When they have the fever, at the peak of the fever they develop the weakness, not like this fever 1 week back, after that 1 week whenever she is afebrile she developed the weakness, not like this, and it is asymmetrical in poliomyelitis. So, anti-onset. So, no disease can explain her problem like this, it is acute onset. Suppose if it is a chronic over years, then you would have thought of a motor neuron disease, anti-onset disease. Can it be a spinal cord anatomical localization? Spinal cord, to say there should be a bowel and bladder involvement and definite sensory level. She does not give history of any sensory level, or there is no history of bowel and bladder involvement. Bowel and bladder is normal, there is no sensory level. So, spinal cord is ruled out. Anatomical localization, spinal cord is ruled out. So, most probable anatomical localization in her is anterior root, multiple anterior root, acute onset, and everything happened after the history of fever and loose motion 1 week after that, and it is ascending from lower limb to the upper limb. Probably anatomical localization I want to localize in the anterior root. And what is the pathology? It is acute after the infection. So, probably autoimmune disease, inflammatory, demyelinating polyradicular neuropathy, AIDP. What are the other diseases which can present like this acute motor weakness? Porphyria, cannot be porphyria. Porphyria, they will have abdominal pain, vomiting, then urine they may complain, the color discoloration, long standing if they keep the urine. Porphyria is another DD in this sort of cases where acute motor weakness of both upper limb and lower limb. Can be diphtheria? Diphtheria in 30% can be a descending paralysis, but here it is ascending paralysis. Lower limb first involved and then the upper limb. Can it be a transverse myelitis? As I told, transverse myelitis can occur after fever, whatever she had like this, or a loose motion can occur. But transverse myelitis anatomical localization is spinal cord. So, they will have bowel bladder at definite level, or some sensory disturbance they may complain, loss of sensation and history wise only. Did she complain of sensory symptoms? No. No bowel and bladder. So, you cannot think transverse myelitis. So, transverse myelitis, poliomyelitis, porphyria, OP poison, there is no history of any OP poison in there. OP poison can have a motor weakness, critical care myopathy and neuropathy. Patient those who are in ICU for 1 month, 2 months, because of the toxins acting on the axons and the muscles, they can develop a proximal muscle weakness, a critical care myopathy and neuropathy. And neuromuscular junction disorders, hypokalemic periodic paralysis will be having relapsing and remitting. Diurnal variation of the weakness will be there in neuromuscular junction disorder. Periodic paralysis will be remitting and relapsing, they will have multiple attacks. So, these are some of the DDs which you can consider in this case, okay? And you can approach the case. Probably anterior root is involved and it is acute after the fever and loose motion. So, inflammatory, demyelinating polyradicular neuropathy, probably AIDP, Guillain Barre Syndrome is a diagnosis by history wise. History is so important, student. CNS is very simple, either you come from top to bottom or bottom to top, localize the mode of onset, progression, that gives the pathology, then the diagnosis. So, at each level I will be discussing one case, so that to make you perfect in CNS, at each level from peripheral nerve to the muscle to the neuromuscular junction disorder, root, spinal cord, cortex, everywhere at each level one case I will be discussing you. So, this is the case where the problem is in the anterior root, multiple roots with the history wise, history analysis. Let us see on examination what findings we get, whether that is fitting into that or not. Again, I will tell the two findings now. Whatever the findings which was there on December 9th when this patient was seen initially, that findings also I will tell, and what are the findings she is having right now also I will tell. So, how the disease has progressed over 2 months from December 9th to the February 14th. So, we will analyze and we will discuss that. So, general physical examination, patient lying on the bed, cooperative, conscious and oriented, moderately built and nourished, weight is 58 kg, height is 152 centimeters, BMI is 25. No pallor, icterus, clubbing, cyanosis, lymphadenopathy or edema. Vitals, pulse 80 beats per minute, regular, normal volume and character, no collapsing pulse, no radial or radiofemoral delay, all peripheral pulses felt and it is normal. Blood pressure is 130 by 70 mm of Hg in the right arm supine position, and here you have to check for a postural hypotension, especially in this case because they will have autonomic symptoms, Guillain Barre Syndrome patient. So, you have to check for any postural hypotension is there or not in this patient. Respiratory rate 16 beats per minute, thoraco-abdominal, and she is afebrile right now. Head-to-toe examination, there is nothing significant relevant to the disease what we are thinking in this case. Okay. Coming to the central nervous system examination, higher mental function, patient is conscious, oriented to time, place and person, intelligence and attention is adequate, appearance and behavior is normal, memory and speech is intact, no delusion or hallucination. So, high mental function is normal in that. Cranial nerves, olfactory is normal, optic nerve, visual acuity bilaterally it is normal, field of vision is normal bilaterally, color vision is normal, fundus is normal. The disease what you are thinking AIDP can have a papilledema due to the increased protein in the CSF. They can have papilledema. Increased protein in the CSF will produce papilledema. That is one finding which is relevant to this case. Then third, fourth and sixth cranial nerve examination is important in this case, okay, along with the seventh nerve, because one variety of Guillain Barre syndrome, Miller-Fisher variant, they will have ophthalmoparesis, areflexia and ataxia. In that perspective, it is important third, fourth, sixth cranial nerve examination, and seventh nerve will be involved in 50% of the case of Guillain Barre syndrome. So, the seventh nerve examination is also important in this case. Let me examine both the cranial nerves. Students, quickly I will examine third, fourth, sixth and seventh cranial nerve. ಬಾರಮ್ಮ ನಾನು ಬೆರಳೇ ನೋಡಬೇಕು, ಮೇಲೆ ನೋಡಿ, ಈ ಸೈಡ್ ನೋಡಿ, ಈ ಸೈಡ್ ನೋಡಿ, ಕತ್ತಲಾಡಿಸ್ಬಾರ್ದು, ಮೇಲೆ ನೋಡಿ, ಈ ಸೈಡ್ ನೋಡಿ, ಈ ಸೈಡ್ ನೋಡಿ, ಕೆಳಗೆ ನೋಡಿ, ಮೇಲೆ ನೋಡಿ. The movements in all the four cardinal direction is normal. She can move in all the four cardinal direction. Okay. And then other things in the third, fourth, sixth cranial nerve in her is there is no ptosis, no lid retraction, no squint proptosis or no double vision or no nystagmus. She is not having any of the other problems of third, fourth, sixth cranial nerve. Movement of the eyeball is full in all the direction and even there is no Horner syndrome. Pupil size is bilaterally normal, 3 mm round and regular. Light reflex both direct and consensual is normal, accommodation reflex is normal and there is no relative afferent pupillary defect in her. Okay. Fifth nerve, pain and temperature over the face, bilaterally she can appreciate the sensation, it is normal. General sensation over the face is intact and muscles of mastication is normal. Corneal reflex, conjunctival reflex is normal, jaw jerk is absent in her. Coming to the seventh nerve examination, I want to examine the seventh nerve inner because 50% of the cases of the disease which you are thinking AIDP or Guillain Barre, it will be affected. Balamma, nan beru nodi mele, you can see the wrinkles, okay, frontal belly of occiput of frontalis. Kan muchi tight agi, she can close the eyes, saku. Ing madi, madi. Buccinator, normal, saku. Hal torsinge, okay, yeah. So, orbicularis oculi, frontal belly of occiput of frontalis, buccinator is normal. There is no facial deviation to any one side. Seventh nerve is normal. Eighth nerve, Renes is positive both right and left, that is AC is better than BC. Weber's lateralized to equally both the sides. ABC is same as me. So, eighth nerve is not involved. Ninth and tenth, symptom wise there is no nasal regurgitation or nasal twang. Uvula is central. Arch of the palate is equal bilaterally and gag reflex and palatal reflex is intact. It is not affected in this case. But low cranial nerves can be affected in the disease which you are thinking, that is AIDP or Guillain-Barre, which you may mistake for a brainstem ischemia. Brainstem is supplied by the blood vessel. If it undergoes ischemia, there are low cranial symptoms. So, it can be affected, but it is rare. 7th nerve, 50% it will be affected. 11th cranial nerve, turning of the head side to side is normal. Couldn't the shrugging of the shoulder at that time when she was examined on December 9th, she couldn't do because the power was absolutely 0. Now, let us see whether she could do shrugging of the shoulder. Balama, ನಾನು ಹೇಳಿದಾಗ ಹಿಂಗೆ ಮಾಡಬೇಕು ಮಾಡಿ now she can do ಮಾಡಿ yeah. Now she has improved. Now she has improved in over the 2 months. That is why she could do the shrugging of shoulder. 12th nerve, no tongue fibrillation or fasciculation, no deviation of the tongue. This is a cranial nerve examination. Okay. Even on December 9th, there was no cranial nerve involved in her, and now also no cranial nerves are involved in her. Okay. Though it can be involved in the disease which you are thinking, that is AIDP or Guillain Barre syndrome. Okay. Now let us go to the motor system examination. The bulk, right side arm is 22, left side arm is 22. Forearm, right side is 21, left side is 21. Thigh, right side is 39, left side is 38. Leg, right side is 29, left side is 28. So there is no gross difference. Okay. And usually, though it is a element lesion, Guillain Barre syndrome, wasting is not a feature. Why? Because it is a demyelinating disease 90% of the cases. That is why wasting is not a feature of Guillain Barre, though it is a element, because it is a demyelinating disease. But there are some rare axonal variants are there where they can have a wasting, but by and large 90% of the cases, which is AIDP, demyelinating, wasting is not a feature. Tone of the muscle, upper limb and lower limb, it is hypotonia. Okay. First I will check the upper limb now, the tone and the muscle power examination. I will make her lie down, and then I will check the tone at that time of the lower limb and the muscle power examination of the lower limb. Okay. Let me examine the tone in the upper limb. Yeah. So, let me examine the tone in the upper limb. While extending, you have to look for the tone in the biceps muscle. Okay. Straight ಮಾಡಿ ಅಮ್ಮ, straight ಮಾಡಿ. Okay. There is hypotonia. ಇದು ಅಷ್ಟೇ straight ಮಾಡಿ. There is hypotonia. While sleeping, I look for the tone in the lower limb, students. Okay. Let me check the power of the muscles in the upper limb. Now, she is sitting now. I will check the power in the upper limb. Okay. ನಾನು ಹೇಳಿದಾಗ ಕೈನ ಹೀಗೆ ಮಾಡಬೇಕು. ಓಕೆ ಮಾಡಿ. ಶಿ ಕ್ಯಾನ್ ಡೂ. ಓಕೆ, ಬಟ್ ಅಗೇನ್ಸ್ಟ್ ದ ರೆಸಿಸ್ಟೆನ್ಸ್. ಸೊ ಪವರ್ ಇಸ್ 3. ಲೆಟ್ ಮಿ ಶಿ ವೆದರ್ ಶಿ ಕ್ಯಾನ್ ಡೂ ಅಗೇನ್ಸ್ಟ್ ದ ರೆಸಿಸ್ಟೆನ್ಸ್. ಮಾಡಿ ಈಗ. ಶಿ ಕೆನಾಟ್ ಡೂ, ಸ್ಟೂಡೆಂಟ್. ಸಿ. ಓಕೆ, ಸಾಕು 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 ಸಾಕು. ಸೊ ಶಿ ಕೆನಾಟ್ ಡೂ. ಓಕೆ, ಸೊ ದ ಪವರ್ ಈಸ್ 3 is there, 4 minus. Shoulder abduction done by initial 15 degree by supraspinatus, later by the deltoid, the last part will be by the trapezius. Shoulder abduction. Let me check shoulder adduction. ಬಾಲಮ್ಮ, ನಾನು ಹೇಳಿದಾಗ ಕೈ ಹಿಂಗಿರುತ್ತಲ್ಲ, ಒಳಗೆ ತೊಗೋಬೇಕು. ನಾನು ಹೇಳಿದಾಗ ಹಿಂಗಿರುತ್ತಲ್ಲ, ಕೈನ ಹಿಂಗೆ ತೊಗೋಬೇಕು. ನಾನು ಹೇಳಿದಾಗ ಮಾಡ್ತೀರಾ? ನಾನು ಹೇಳಿದಾಗ ಮಾಡಿ. ಒಳಗೆ ತಗೊಳ್ಳಿ. She cannot, she is finding it difficult, students. She is finding it difficult to adduct the adduction of the shoulder joint. The adduction of the shoulder joint is done by pectoralis major and latissimus dorsi. Let me check shoulder flexion and extension. Shoulder flexion movement is, ಬಾಲಮ್ಮ ನಾನು ಹೇಳಿದಾಗ ಈ ಕೈನ ಇಲ್ಲಿಗೆ ಮುಟ್ಕೋಬೇಕು. ನಾನು ಹೇಳಿದಾಗ ಮುಟ್ಕೊಳ್ಳಿ. She cannot do shoulder flexion, students. See, ಸಾಕು ಬಿಡಿ. She cannot do shoulder flexion. Shoulder flexion is done by pectoralis major, anterior fibers of deltoid. Let me check shoulder extension. ಬಾಲಮ್ಮ ಕೈ ಹಿಂಗಿರುತ್ತಲ್ಲ, ನಾನು ಹೇಳಿದಾಗ ಹಿಂಗೆ ಸ್ಟ್ರೈಟ್ ಮಾಡ್ಕೋಬೇಕು. ಮಾಡಿ. She cannot do, students. There is a weakness. Okay, right. Again, all these 4 minus. Shoulder extension is done by posterior fibers of the deltoid and latissimus dorsi. Latissimus dorsi. Shoulder flexion is done by anterior fibers of deltoid, pectoralis major. Okay, right. Let me check elbow flexion, elbow extension. ಬಾಲಮ್ಮ ನಾನು ಹೇಳಿದಾಗ ಕೈನ ಹೀಗೆ ಮಡ್ಚ್ಕೋಬೇಕು. ಓಕೆ, ಮಡ್ಚ್ಕೊಳ್ಳಿ. She is not able to do, students. Sakubadi. She is not able to do. But without resistance, let me see whether she can do anta. Madisಕೊಳ್ಳಿ ಹಿಂಗೆ. She can do. So 4 minus. Okay, elbow flexion. Now elbow extension. Left side, let me check the shoulder, elbow flexion. ಈ ಕೈ ಮಡಚ್ಕೋಬೇಕು. ಕೈ ಮಡಚ್ಕೊಳ್ಳಿ. Not able to do, students. ಸಾಕು. Not able to do elbow flexion on left side also. Now elbow extension. ಕೈ ಇದೆಯಲ್ಲ ಹಿಂಗೆ ಮಾಡ್ಕೋಬೇಕು ಸ್ಟ್ರೈಟ್ ನಾನು ಹೇಳಿದಾಗ ಮಾಡಿ. ಶಿ ಕಾಂಟ್ ಡೂ, ಸ್ಟೂಡೆಂಟ್ಸ್. 4 ಮೈನಸ್ ಮಾಡಿ ಅಮ್ಮ, ಸ್ಟ್ರೈಟ್ ಮಾಡಿ. ಶಿ ಕಾಂಟ್ ಡೂ ದಟ್. ಓಕೆ, ಬೋತ್ ದ ಸೈಡ್ಸ್ elbow extension is 4 minus. But without resistance she can do it. ಕೈಗೆ ಇಟ್ಕೊಳ್ಳಿ, ಹಿಂಗೆ ಮಾಡಿ, ಸ್ಟ್ರೈಟ್ ಮಾಡಿ ಎರಡು ಕೈ. She can do without resistance and against gravity. So the power is definitely more than 3, but 4 minus. Wrist flexion extension. I will check here only because it's difficult to make her lie down again on the table. Ideally should rest on the table and do it. ಮುಷ್ಟಿ ಮಾಡ್ಕೊಳ್ಳಿ. ನಾನು ಹೇಳಿದಾಗ ಹೀಗೆ ಮಡ್ಚ್ಕೋಬೇಕು, ಕೈ ಹೀಗೆ ಮಡ್ಚ್ಕೊಳ್ಳಿ. ಶಿ ಕಾಂಟ್ ಡೂ, ಸ್ಟೂಡೆಂಟ್ಸ್. ರಿಸ್ಟ್ ಫ್ಲೆಕ್ಷನ್ ಈವನ್ ದಿಸ್ ಸೈಡ್ ಮಾಡಿ ಅಮ್ಮ. ಶಿ ಕಾಂಟ್ ಡೂ ಬೋತ್ ದ ಸೈಡ್ಸ್. ರಿಸ್ಟ್ ಫ್ಲೆಕ್ಷನ್ 4 ಮೈನಸ್. ಹೀಗೆ ಇಟ್ಕೊಳ್ಳಿ, ಮುಷ್ಟಿ ಮಾಡ್ಕೊಳ್ಳಿ. ನಾನು ಹೇಳಿದಾಗ ಹಿಂಗೆ ಮೇಲೆ ಮಾಡಬೇಕು ಮಾಡಿ. ಶಿ ಕಾಂಟ್ ಡೂ, ಸ್ಟೂಡೆಂಟ್ಸ್. ಸಿ ಇಯರ್ ವಿತ್ ವೆನ್ ಐ ಅಪ್ಲೈ ರೆಸಿಸ್ಟೆನ್ಸ್ ಮಾಡಿ. She can't do it. So wrist flexion extension is weak. Let me check the hand grip. Very tight ಇಟ್ಕೊಳ್ಳಿ. Students, hand grip is so weak. See here, probably even 10% she is not having. Tight ಇಟ್ಕೊಳ್ಳಿ. So hand grip is totally weak. Okay. Now let me check the power in the lower limbs as well as the tone after lying down. Yeah, let me examine the tone in the lower limb and power in the lower limb. The tone in the lower limb, you can do the movements. If there is a lot of movements, it is hypotonia. This is one method. The other method is you lift the leg on the ground. It comes like this. ನೀವೇನು ಮಾಡಿಬಿಡಿ ಬಾಲಮ್ಮ, ಸುಮ್ಮನೆ ನೀವು ಆರಾಮಾಗಿರಿ. ನಿಮ್ಮ ಪಡೆ ನೀವು ಸುಮ್ಮನೆ. Okay, this is another way. If it is hypertonia, the whole leg will lift up like that. That is hypertonia. Okay. So there is a hypotonia in the lower limb. Let me check the power in the lower limb. Okay. Hip flexion I want to check. Ideally you have to check with the hand under the knee, and I don't want to trouble her, embarrass her. Kaal mele kitti balama. This is again 4 minus, students. Difficult for her. Ee kaal matra. Not foot. Saak bidi. So totally she is not able to do that. Probably this is 4 I will give, not 4 minus like upper limb. I will give 4 to the right lower limb. Left lower limb, let me check. Ketti kaalu. This is also 4 I will give. She is able to do that, but not normally. Okay, 4. Hip extension is also 4, students. Ideally she has to make a prone and examine. How to examine for the hip extension I have taught in the general examination of the CNS. Because she is female and very old lady, I don't want to trouble her. Okay. Hip extension is also 4. Let me check knee, the hip abduction, adduction. ಬಾಲಮ್ಮ, ನಾನು ಹೇಳಿದಾಗ ಈ ಕಾಲು ಇದೆಯಲ್ಲ ಹಿಂಗೆ ಮಾಡಬೇಕು. ನಾನು ಹೇಳಿದಾಗ ಮಾಡಿ. She is able to do, students. So probably this 4 plus I will give, not a normal, 4 plus I will give for a hip abduction. Hip flexion is by iliopsoas, hip extension is by gluteus maximus. Hip abduction by gluteus medius and minimus. This I am repeatedly telling in all the cases just for a revision purpose. Hip adduction is by adductor group of muscles. Let me check hip adduction. ಬಾಲಮ್ಮ, ಈ ಕಾಲು ಹೀಗಿದೆಯಲ್ಲ ಹಿಂಗೆ ಒಳಗೆ ತೊಗೋಬೇಕು ನಾನು ಹೇಳಿದಾಗ. ಓಕೆ, ತಗೊಳ್ಳಿ. She can do, students. She can do. Probably it is less, so I want to give 4 plus. Probably 4 plus I want to give to the hip adduction. Knee extension, knee flexion. ಕಾಲು ಮಡಚ್ಕೊಳ್ಳಿ, ಸ್ಟ್ರೈಟ್ ಮಾಡಿ ಕಾಲ. She can probably 4 plus I will give, done by quadriceps group of muscles. ಮಾಡಿ, ಸ್ಟ್ರೈಟ್ ಮಾಡಿ. Yeah, this is also she is able to do. Probably 4 plus I will give for a knee extension. Knee flexion, ideally you have to make a prone. I don't want to trouble her. Okay, for hamstring group of muscles. That is also 4 plus is there in her, the knee extension. dorsiflexion, plantar flexion, inversion, eversion. ಈ ಪಾದ ಇದೆಯಲ್ಲ ನಾನು ಹೇಳಿದ ಹಿಂಗೆ ಮೇಲ್ ಮಾಡಬೇಕು ಮಾಡಿ. ಯಾ ಸಿ ಕ್ಯಾನ್ ಡೂ ಪ್ರಾಬಲಿ ಫೋರ್ ಐ ಕ್ಯಾನ್ ಗಿವ್ ಸ್ಟೂಡೆಂಟ್ಸ್. ಈ ಪಾದನ ಕೆಳಗೆ ತರಬೇಕು ಹಿಂಗೆ ತನ್ನಿ. ಯಾ 4. ಈ ಪಾದ ಹಿಂಗೆ ಮೇಲ್ಗೆ ತರಬೇಕು, ತೊಗೊಂಬನ್ನಿ ಮೇಲಕ್ಕೆ. ಯಾ ಪ್ರಾಬಲಿ 4 ಅಗೇನ್. ಈ ಪಾದ ಕೆಳಗೆ ತರಬೇಕು, ಕೆಳಗೆ ತೊಗೊಂಬನ್ನಿ. ಓಕೆ. ಸೊ ಪ್ಲಾಂಟರ್ ಫ್ಲೆಕ್ಷನ್, ಡಾರ್ಸಿಫ್ಲೆಕ್ಷನ್, ಇನ್ವರ್ಷನ್, ಎವರ್ಷನ್. ಅಲ್ಲಿ ಎಕ್ಸ್ಪ್ಲೇನರ್ ಫಸ್ಟ್ ಬಲ್ಲಮ್ಮ. ಈ ಪಾದ ಇರ್ತಲ್ಲ ನಾನು ಹೇಳಿದಾಗ ಇಲ್ಲಿ ಮುಟ್ತೀನಿ, ಹಿಂಗೆ ಮಾಡಬೇಕು. ಇಲ್ಲಿ ಮುಟ್ಟಿದಾಗ ಹಿಂಗೆ ಮಾಡಬೇಕು ಪಾದನ. ಆಯಿತಾ? ಹೆಂಗೆ ಅಂದರೆ ಇಲ್ಲಿ ಮುಟ್ಟಿದಾಗ ಹಿಂಗೆ ಮಾಡಬೇಕು, ಇಲ್ಲಿ ಮುಟ್ಟಿದಾಗ ಹಿಂಗೆ ಮಾಡಬೇಕು. ಓಕೆ, ಅರ್ಥ ಆಯ್ತಾ? ಓಕೆ. ಯಾ ಐ ಜಸ್ಟ್ ಎಕ್ಸ್ಪ್ಲೈನ್ ದ ಇನ್ವರ್ಷನ್ ಆ್ಯಂಡ್ ಎವರ್ಷನ್ ಮೂಮೆಂಟ್ ಟು ಹರ್. ಲೆಟ್ ಮಿ ಚೆಕ್ ದ ಇನ್ವರ್ಷನ್ ಆ್ಯಂಡ್ ಎವರ್ಷನ್. ಮಾಡಿ. ಹಾಗಲ್ಲ, ಹಿಂಗೆ ಮಾಡಬೇಕು ನಾನೇ ಮಾಡಿ. ಡಿಫಿಕಲ್ಟ್ ಫಾರ್ ಹರ್. ಇದು ಮಾಡಿ. ದಿಸ್ ಆಲ್ಸೋ ಶಿ ಈಸ್ ಫೈಂಡಿಂಗ್ ಇಸ್ ಡಿಫಿಕಲ್ಟ್. ಇದು ಮಾಡಿ ಈಗ. ಈಗ ಮಾಡಿ, ಹಿಂಗೆ ಮಾಡಿ. She is finding it difficult for inversion and eversion to get it. Probably she has not understood properly. Okay, I couldn't able to make her understand. Anyhow, so in the lower limb, it is 4 in some group, 4 plus in some group, but upper limb definitely 4 minus in all the groups. Okay, right. Students, when she was examined on December 9, before referring to one of the higher hospital, it was 0 in power. After 1 week of the treatment in that hospital, when she came back to our hospital, power improved to 2/5. In 2 months, over the last 2 months, she has progressed to this level. Now it is 4 minus in the upper limb, 4 or 4 plus in the lower limb. This is a progression of that disease, whatever she had, from December 9th, 2020 to February 14th of today, which I am presenting the case. Because of the difficulty in treating the patient for a shooting and all, that is why we are presenting today. At least we can mobilize her. That is the reason. Right. So the power of the examination over. Coordination, students, important in this case because one of the variant of a Guillain Barre Miller-Fisher variant syndrome, they will have areflexia, ophthalmoparasis and ataxia. You have to examine cerebellar system examination. On that 2 months back, cerebellum system couldn't be examined, power was because less than 3, but now power is 3/5, more than 3/5, 4 minus, and our cerebellar system examination is normal. The finger to finger nose, knee heel test are intact. It is normal. It is not abnormal in her. And even speech is normal, no dysarthria, no nystagmus, okay, no dysdiadochokinesia, no Holmes rebound phenomena. Cerebellum system examination is normal. Coming to the reflexes, very important students, reflexes. When she was examined before referring to a higher hospital on December 9, 2020, all the reflexes were absent. All the reflexes were absent. Universal areflexia was there. Very important students, throughout your life you have to remember universal areflexia is a feature of AIDP or Guillain Barre Syndrome. What has happened to our reflexes? Now let us see. So let me examine the biceps reflex. It is present, students, biceps on the right side. I am able to get it. Brachioradialis is sluggish. Triceps couldn't be able to elicit. Left side biceps, triceps and brachioradialis is absent, students. Okay, only right side biceps is present, brachioradialis is sluggish. Let me check the knee and ankle jerk. So let me examine the knee and ankle jerk. It is absent, students, right knee jerk. Let me check the left knee jerk. I don't want to expose her because she is a female. With the cloth only I am eliciting the reflex. Now I am not able to get even left knee. Let me check the ankle jerk. ಸುಮ್ಮನೆ ರೇ ಏನು ಮಾಡಿ. ಟೈಟಾಗಿ ಹಿಡಿಬಾರ್ದು ಆ ಥರ. So both the ankle jerk I am not able to get it, okay, and knee jerk also I am not able to get it, but right side biceps is present, okay. At that time 2 months back there was universal air reflexia. Now right biceps is present. Probably she is recovering with the treatment. That is the reason why I got only biceps probably recovering. That is why I got a biceps reflex present, okay. Right. Coming to the superficial reflexes, corneal reflex, conjunctival, gag reflex, everything is present, normal, okay, right. Abdominal reflex is present and plantar is mute. I want to demonstrate the plantar, that is important in this case because one of the DD what we thought was transverse myelitis involving the spinal cord. So let us examine the superficial reflexes in our students. The corneal reflex, conjunctival, palatal gag reflex, abdominal reflex, everything is present. Plantar reflex is very important in her because one of the DD what you thought in her is acute transverse myelitis. What do you expect in acute transverse myelitis? The plantar should be extensor. Let us see whether it is extensor or not. It is coming neither flexor or extensor, students, mute. Even left side also it is coming mute, neither flexor nor extensor. Okay. So it is not extensor. One of the DD what you thought was transverse myelitis, so it is not extensor, okay, right. Next coming to the sensory nervous system examination, which is very important in this case, students, okay, sensory nervous system examination. So at that time 2 months back when she was examined, her sensory system was normal. She could appreciate the fine touch, vibration, joint position sensation, everything was normal. Let me examine now. I do not know to expose her because she is a female. Some only the exposed parts of the body where I can test, I will just check grassly for the fine touch and pain and vibration. Let me check whether she can appreciate it or not. ಬಾಲಮ್ಮ, ನಾನಿದು ಮುಟ್ಟಿದಾಗ ಗೊತ್ತಾದರೆ ಒಂದು ಅಂತ ಹೇಳಬೇಕು, ಆಯಿತಾ? ಕಣ್ಣು ಮುಚ್ಕೊಳ್ಳಿ, ಗೊತ್ತಾದರೆ ಒಂದು ಅಂತ ಹೇಳಬೇಕು. ಫಸ್ಟ್ ಲೆಟ್ ಮಿ ಎಕ್ಸಾಮಿನ್ ಆನ್ ದ ಫೇಸ್, ಓಕೆ students. Let me examine the sensory system examination in her, which is very important because the disease which you are thinking AIDP or Guillain Barre, it will be normal. Majority of the patients it will be normal. I am talking in general, okay, right. ಬಾಲಮ್ಮ, ಮುಟ್ಟಿದಾಗ ಗೊತ್ತಾದರೆ ಒಂದು ಅಂತ ಹೇಳಬೇಕು. ಕಣ್ಣು ಮುಚ್ಕೊಳ್ಳಿ. In the lower limb, I will check. I do not want to expose her because she is a female, she has covered the cloth. Yeah. So by and large, fine touch is normal. Whichever the areas I tested, it is normal. It is not affected. Let me check the pain and vibration. Let me check vibration. Vallama, ಇದು ನಾನು ಇಟ್ಟಾಗ ಇದು ಹಿಂಗೆ ಗುಯ್ ಏನೋ ಗೊತ್ತಾರೆ ಒಂದು ಅಂತ ಹೇಳಬೇಕು. ಯಾವ ಥರ ಗೊತ್ತಾ? ಹಿಂಗೆ ಅಲ್ಲಾಡೋದು ಗೊತ್ತಾಗುತ್ತಲ್ಲ, ಆ ಥರದ್ದು ಗೊತ್ತಾರೆ ಹೇಳಬೇಕು. ಓಕೆ. I just explained her the sensation. Now I will just put on the bony prominences. ಕಣ್ಣು ಮುಚ್ಚಬೇಕು. Yeah. Upper limb normal, lower limb let me examine. Yeah. You have to give her the explanation that the vibration sensation she should appreciate, not the touch sensation. After that only you have to examine the vibration. You have to always do vibration sensation with 128 tuning fork. So vibration is normal, carried by posterior column. Fine touch is normal, carried by posterior column. Let me examine the pain. ಬಲ್ಮ, ನಾನು ಇದು ಮುಟ್ಟಿದಾಗ ಗೊತ್ತಾದರೆ ಒಂದು ಅಂತ ಹೇಳಬೇಕು. ಆಯಿತಾ? ಕಣ್ಣು ಮುಚ್ಕೊಳ್ಳಿ. Now I will be examining the pain. Let me start on the face and then I will come to the body. Kan muchkoli. Let me examine on the lower limb, okay, which are the exposed areas. So, pain sensation is normal, vibration is normal, fine touch is normal. Very important part of the examination in this case, students, because transverse myelitis is what you are thinking, long tract will be involved in the spinal cord. So, they will have a sensory affection, but here it is not affected. A sensory definite level will be there in spinal cord, but here sensation is normal. So, spinal cord is not the problem at all here, and plantar is mute. If transverse myelitis, plantar will be extensor because it is a spinal cord disease. The cortical sensation is also normal, tactile localization, 2-point discrimination, stereognosis, graphesthesia. The double stimulation sensation is also normal. Okay. Romberg sign is negative. She could stand, okay, with the eyes closed, okay, and the joint position and position sensation, which is carried by posterior column, that is also normal. I examined on her. That is also normal. So there is no signs of meningeal irritation. Skull and spine is normal, and gait only with the help she can walk. We have to hold. She cannot walk on her own, okay, because the power in the lower limb is around 4 plus, and she couldn't walk on her own, students, and she cannot climb on the steps. Okay. So, with the 2 people help, we shifted her for the presentation of the case today. Okay. So, her gait with the help she can walk. Autonomic nervous system is normal. Other system examination, central cardiovascular system examination is normal, no murmurs. GIT, no organomegaly. Respiratory system is normal. Okay. So, now we have examined her. What are the positive findings we got in her? Her higher mental function is normal. Cranial nurse is normal. Motor system, there is hypotonia, no wasting. There is a weakness, bilaterally symmetrical weakness in both the upper limb and lower limb, which was 0 initially, gradually now improved till the 4 minus 4 plus at different levels. Reflexes, universal areflexia 2 months back. Now also there is areflexia is present, only in the right biceps reflex is present, or else now also there is a absent reflexes. Universal areflexia. Sensory system is absolutely normal. At that time also 2 months back, now also sensory system is normal, cerebellum is normal, and plantar is mute, it is not extensor. So, she has got LMN signs: hypotonia, weakness, plantar mute, and sensory system not affected. So, what are the disease which you thought at the end of history? You thought neuromuscular junction disorder, at history level only you ruled out. Anything in the examination which is against neuromuscular junction disorder, deep teton reflexes will be normal in myasthenia gravis, but here it is absent. You thought transverse myelitis. What are the point against that? There is no sensory level, history-wise bladder ball is not involved, and plantar is mute here. So, transverse myelitis unlikely. History-wise only you ruled out diphtheria, poliomyelitis because it is asymmetrical, and porphyria also, hypokalemic periodic paralysis also, you ruled out history-wise only. In hypokalemic periodic paralysis, the deep teton reflex will be sluggish to absent. So, probably 99% with history and examination, she is fitting into acute inflammatory demyelinating neuropathy, AIDP, Guillain Barre Syndrome. Okay, students. So, a very nice case, a methodical, logical way to approach a case, this one. Okay. Then how do they investigate it? I want to tell the investigations, whatever done on her, and then I will go to a detailed discussion about AIDP. Students, on 3rd December 2020, they have done a MRI brain, which was showing normal. We didn't thought of any brain CNS cause for her quadriparesis in her. So, only for exclusion of the other diseases, they have done a MRI, which is normal. Okay. On MRI cervical spine they have done, because as I told, a traumatic involving the spinal cord, a transaction, okay, spinal cord anatomical localization can produce a quadriparesis, okay. So, MRI spine they have done, that is also showing normal, there is no any dislocation, fracture dislocation of the spine, that is normal. They have done a CSF study, very important in this case to diagnose. Okay, what do you expect? Albuminocytological dissociation, that means proteins will be elevated, cells will be less or absent. Why and all I will tell in the discussion later again. And in her, the CSF glucose is 134, CSF protein is 39.26, WBC is 1. So, there is no cells, but you know, for unusual reason I do not know, protein is not that much elevated in her. Usually it will be between 100 to 1000 milligram per deciliter in Guillain Barre syndrome. If you do very early, within few days, 1 or 2 days, at that time CSF may not show the classic picture. After 1 week it will show the picture. Probably this may be little earlier stage they have done a CSF, that is the reason why it is not showing a classic picture of albuminocytological dissociation. Normal protein is around 30, here it is 39. You expect in the range of 100 to 1000. Why you get more protein in Guillain Barre? Demyelination. The myelin proteins will go to the CSF, that is why you get a more protein, that is the reason. And it is not infective, that is why cells will not be there, that is why albuminocytological dissociation you get it. Then the next study is the nerve conduction study, very important. The nerve conduction study showed in her predominantly motor demyelinating polyneuropathy. Again, nerve conduction study will lag behind the clinical features, students. It will take little time to develop, but in her it has already showing at that time only predominantly motor demyelinating polyneuropathy. The F wave were absent, distal latencies were there, conduction block was there, H reflex is delayed. I will explain in detail what all those when I discuss Guillain Barre syndrome in detail after the discussion of this clinical discussion. So, F waves were prolonged, H reflex is absent, distal latencies were there. I will tell what are those things when I discuss the case. But in her, the disease is showing typically the motor demyelinating polyneuropathy. So, students, 2 months back after she diagnosed AIDP, immediately treatment was started because each minute and each hour counts. They have started on IV immunoglobulins in her. They gave the standard dose of 2 grams per kg body weight and see the improvement in 2 months. At that time it was 0/5, now she has improved and still there is room for improvement. Till 1 year they can improve, probably 85% of the patients will regain the normal power. So, this much is the improvement and we thought probably this is the ideal time to shift her and present now. That is why we are presenting this case at this time after 2 months. Now, let us come to the detailed discussion of Guillain Barre syndrome. Guillain Barre syndrome is frequently fulminant disease of autoimmune etiology. It is a demyelinating polyradiculoneuropathy. Multiple anterior roots will be involved with the demyelination and it is an autoimmune etiology, frequently fulminant. The incidence is around 1 to 4 per 1 lakh patients. It occurs throughout the year, there is no season like that. In one season Guillain Barre will come, other season it does not come, nothing like that. It occurs throughout the year. Affect all the age group according to Adams, but Harrison says adults are slightly more compared to children and females are slightly more the males are slightly more compared to females in Harrison, but Adams gives all the age group, all the sex, throughout the world, everybody can get affected by Guillain Barre syndrome. What are the clinical feature of Guillain Barre syndrome? It is areflexic ascending paralysis. Ascending means not the distal is first and then proximal muscle, do not confuse by that. Ascending means lower limb first, then upper limb next. That is the ascending meaning. Same classic inner. She had a lower limb weakness first and then she developed the weakness of the upper limb. So, it is a areflexic ascending motor weakness. The motor weakness will be both proximal and distal, though it is a radiculoneuropathy. This is one radiculoneuropathy where usually in a peripheral neuropathy distal weakness will be predominant, but Guillain Barre is one radiculoneuropathy where proximal will be equal to distal involvement or sometimes more. Sensory symptoms, subjective symptoms they may complain, the neck pain, shoulder pain, back pain. Or dysesthetic pain they may have if sensory nerve is involved, which is rare. And on examination, pain and temperature won't be affected, but in some of the patients fine touch, vibration, joint position sensation can be affected in some of the patients. Facial nerve will be involved in 50% of the cases. The lower cranial involvement can be there, the bulbar involvement, where you may mistake that for a vertebrobasilar ischemia, some patients. Even if it is a mild, they will have autonomic symptoms, but our patient did not have the autonomic symptoms, especially in a fluctuation of a BP or arrhythmias they may develop autonomic dysfunction, even if it is a mild case. Deep tendon reflexes will be absent within the first week only. Bladder involvement, it won't be there. If in a severe case, if it is there, it will be only transient. A persistent bladder symptom which is coming early and a definite sensory levels, your anatomical localization is spinal cord. You have to think of transmyelitis. 30% of the patients requires mechanical ventilation. Those who require mechanical ventilations are those who come with a quadriparesis, rapid progression of the disease, involvement of the bulbar cranial nerves. They require mechanical ventilation probably in 30% of the cases. One more thing, students, whenever they have the paralysis or a weakness like this, at that time they won't have fever. If fever is there at the time of motor weakness, your diagnosis is question mark of Guillain Barre. It should not be Guillain Barre. But they may have a fever, upper respiratory infection 1 to 3 weeks prior to the episode. There are different variants of Guillain Barre syndrome. 90% of the times it is acute inflammatory demyelinating polyneuropathy, AIDP. That is only myelination, demyelination, AIDP. There are 2 axonal variants, acute motor axonal neuropathy, AMAN, acute motor sensory axonal neuropathy, AMSAN, where axon will undergo degeneration. There can be some restrictive and localized types of Guillain Barre syndrome, special variants, Miller-Fisher variant syndrome, where they will have ophthalmoparesis, areflexia and ataxia with the GQ1B antibody, or there can be a bulbar and a facial nerve variety of a Guillain Barre syndrome, where GM2 antibodies will be there, or there can be a ophthalmoplegic variant, plain ophthalmoplegic variant, or some rare variant sensory forms, pan dysautonomia, only autonomic dysfunction. These are very rare forms, students. 90% is AIDP. What are the predisposing factors to develop Guillain Barre syndrome? 70% of the patients will have preceding within 1 to 3 weeks either the upper respiratory tract infection or diarrhea. Like in her, she had fever, loose motion 1 week back. Typically she presented. After that, the symmetrical weakness of both upper limb and lower limb. 30% of the cases is due to Campylobacter jejuni infection. Similar percentages of the infection can occur due to hepatitis, cytomegalovirus, Epstein-Barr virus. Other viruses like HIV, herpes, Zika virus, mycoplasma pneumonia are implicated in Guillain Barre syndrome. Guillain Barre syndrome occurs more than chance association with SLE, lymphoma, HIV, and a recent vaccination, especially for rabies vaccination, the older neural vaccinations are used to produce Guillain Barre syndrome. These are the predisposing factors, lymphoma, even post-surgical some books has given. So, the main 4 variants I want to discuss, the pathology and in whom it is more common. The acute inflammatory demyelinating polyneuropathy, AIDP, 90% where it is common. It is more common in adults compared to the children. The classic what she is having, AIDP. More common in adults compared to children. It recovers rapidly like in her. The pathology is the first attack of the autoimmunity will be on the nodes of on the Schwann cell. It attacks the Schwann cell, the autoantibodies. Both lymphocytes and macrophages will be there. They will go and destroy the Schwann cell. The second variety is AMAN, acute motor axonal neuropathy. Here both children and adults can occur with equal frequency. It also recovers rapidly, AMAN as a good recovery. Here the problem will be, the attack will be the first attack of autoimmunity when the nodes of Ranvier, where axons are there. It will go and attack the nodes. And here macrophages are more compared to lymphocytes in the cells, inflammatory cells. third variety is AMSON, acute motor sensory axonal neuropathy. This also adults are more common compared to the children's, but here recovery is slow because this is a more aggressive damage will occur here. And here also like AMON, the predominant cells is the macrophages and attack will be on the nodes of Ranvier. Then the next variety is Miller-Fisher variant variety. Miller-Fisher variant variety, adults and children are equally affected. The pathology is same like AADP, acute inflammatory demyelinating polyneuropathy, and it also recovers, Miller-Fisher variant syndrome. It is both axonal as well as demyelinating, Miller-Fisher variant. It is both axonal as well as demyelinating. So, what is the pathophysiology and pathogenesis of Guillain Barre syndrome? Here both cellular immunity and humoral immunity will come into picture. It is a molecular mimicry. That means, what are the infections she had or any patient of ADP will have against the virus or bacteria, those antibodies will go and react on these nerves and damage the nerves because of the mimicry of the antigen, antigenic mimicry. The antigen which is targeted is glycoconjugates, that is gangliosides. Gangliosides are glycosphingolipids with the sialic acid expressed on the plasma membrane of the neural cells. So, it will go and damage. The GQ1B is seen in Miller-Fisher variant, GM1 is seen in AADP, and Amman and Amsan, some variety of Amman and Amsan, GM12 is seen, especially after Campylobacter jejuni infection. GQ1B antibody is present only in the ophthalmic nerves, not in any other neural tissues. That is why Miller-Fisher variant syndrome, GQ1B antibody is positive, not other antibodies. In an AADP like this, usually they recover nicely, rapidly they recover. If it is a proximal axonal, the recovery is late. Sometimes in a demyelinating AADP like this, secondary axonal damage can occur. If the secondary axonal damage occurs, the recovery is late again. And in axonal variety, like in Amman, acute motor axonal neuropathy, the damage is in the peripheral nerves. That is why the recovery is rapid in Amman, but in AMSON it is proximal. That is why recovery is late there. So, if a distal nerves are damaged, it can sprout, it can regenerate and then improve. This is the pathogenesis and pathophysiology, and in that nerve cell there are three areas where it can go and attack. One is the nodes of Ranvier, where the voltage gated sodium channel will be attacked, and paranodal area where contactin associated protein will be attacked, and juxtanode where voltage gated potassium channel will be affected. So, node, paranode, juxtanode. Node is voltage gated sodium channel, paranode is contactin associated protein, juxtanode is voltage gated potassium channels, which can be attacked by the autoantibodies. Now, what are the autoantibodies which are present in different varieties of Guillain Barre syndrome? In a Guillain Barre syndrome classic AADP, 50% of the patients can have anti-GM1 autoantibody, which is IgG. If facial nerve diplegia is there, it may not be associated with any autoantibody. In Amman and Amson, acute motor axonal neuropathy, acute motor sensory axonal neuropathy, they will have anti-GD1A along with GM1 antibody. If it is a Miller-Fisher variant, they will have GT1A and GQ1B. GQ1B is very specific. There are different varieties, ophthalmoplegia without ataxia, ataxia without ophthalmoplegia. In both also GT1A and GQ1B will be there, antibodies, autoantibodies. Same Becker-Staff variety of Guillain Barre, there also GT1A, GQ1B will be there. Then pharyngo-cervico-brachial variety, where they will have GT1 antibody more compared to GQ1 and compared to GD1. These three antibodies will be there in pharyngo-cervico-brachial variety. Some of the autoantibodies, these are all IgG types. In CIDP, less than 10% of the patients will have autoantibodies against the contactin and neurophysin 155, which is of IgG4 type. In 25% is associated with monoclonal gammopathy of unknown significance, where they will have IgG and IgA couple autoantibodies. These are some of the autoantibodies in Guillain Barre syndrome. Now, how do you investigate a patient with Guillain Barre syndrome? So, two tests, one is CSF analysis, another is nerve conduction study. CSF analysis, the initial first 2 days may be normal, Only at the end of first week you develop albuminocytological dissociation, which is a classic feature of Guillain Barre syndrome. The cells range between 100 to 1000 cells per deciliter, proteins, cells won't be there in CSF. Protein will be in the range of 100 to 1000 milligram per deciliter, 100 to 1000 milligram. Inner it is 39, probably they might have done a very early lumbar puncture. So, protein will be 100 to 1000 milligram per deciliter, but cells won't be there. Why you get protein in CSF? You get because the demyelination of those proteins will enter the CSF. The roots will traverse the spinal cord. So, spinal cord is covered by CSF. When demyelination occurs, those myelin proteins will enter the CSF, so you get a more protein. But it is just an auto antibody, no infection. That is why cells won't be there in CSF. That is why you get albuminocytological dissociation. But there are some conditions where there can be cells in CSF, very rare conditions like lymphoma, leukemia, HIV, sarcoidosis. You may get cells in the CSF. So, after CSF, nerve conduction study. Nerve conduction study students, it is a demyelination will be occurring. So, the features of demyelination, especially in the AIDP, you get conduction velocity is slowed, conduction velocity block, conduction block, the velocity will be reduced as happened in her. Then F wave and H reflex. What is that F wave and H reflex? F wave means, for example, if you stimulate a nerve, it will traverse orthodromically and it will stimulate the nerve, you get a muscle action potential. But the conduction also occurs antidromically, retrogradely to the anterior horn cell. Again it sends one more impulse which will produce one more muscle action potential which is very small, that is a F wave. That F wave will be absent or reduced in AIDP because anterior root is damaged. Next, H reflex. H reflex is nothing but whatever the DTR what you elicit here, no, you give a stimulus to the tendon, but there electrode will give the stimulus and that will elicit a reflex. Because anterior root is damaged in AIDP, H reflex will be absent in AIDP. So, absent H reflex, delayed or absent F wave. Then distal latency. Distal latency is you stimulate a median nerve at the wrist and the time taken by that stimulus to elicit a response in the thenar muscles is known as a distal latency. That will be prolonged in AIDP. Then temporal dispersion, one more feature of demyelination disease. What is temporal dispersion? The amplitude of the muscle action potential will reduce, duration will increase, that is the temporal dispersion. The amplitude will reduce, the duration will increase. So, our patient had a classic demyelinating nerve conduction study picture. Again, nerve conduction study will lag behind the clinical picture, students. You won't get whenever she had initial days only. It takes time to develop the nerve conduction study. These two are the important tests in Guillain Barre syndrome, the CSF nerve conduction study. Then there are two criteria for Guillain Barre syndrome to diagnose, Brighton criteria and Asbury criteria. Brighton criteria I will discuss both for Guillain Barre as well as Miller-Fisher variant syndrome now. For Guillain Barre syndrome, the level 1 evidence is there should be a symmetrical motor weakness, there should be universal areflexia, then the time duration from the onset of disease to the nadir of the disease should be between 12 hours to 28 days. Students, in Guillain Barre syndrome, once the patient reaches a plateau, afterwards the worsen does not occur. Clinical features will keep on worsening, reaches a plateau, does not worsen. If it worsens more than 9 weeks, then it becomes CIDP, which I will discuss later in detail. So, one is symmetrical weakness, universal areflexia. The time duration from the onset of disease to the nadir is 12 hours to 28 days. Electrodiagnostic test suggestive of demyelination or CSF showing cells less than 50 with the high protein. The fifth is there should be no other diagnosis which can be suggestive of this one, Guillain Barre picture like this. These are the level 1 criteria for Guillain Barre syndrome. Level 2 criteria is same, universal areflexia, symmetrical motor weakness, The time duration from the onset of disease to the nadir is around 28 days, but the fourth will differ here. Protein may or may not elevated, he says, protein may or may not elevated. Or if CSF couldn't be taken, electrodiagnostic picture should be suggestive of Guillain Barre syndrome. And the fifth remains the same, no other diagnosis should explain the symptoms. This is level 2 criteria for Guillain Barre syndrome. Level 3 criteria is, the first two remains the same, symmetrical weakness, universal areflexia, the time duration from the onset of disease to the nadir is around 28 days. The fourth is not there, no investigation here, no electrodiagnostic, no CSF, but the fifth one will be there, that is, no other disease should explain the symptoms whatever the patient is having. These are the three levels of Brighton criteria for Guillain Barre syndrome. Let me explain you the Brighton criteria for Miller-Fisher variant. Miller-Fisher variant level 1 is ophthalmoparesis, ataxia, areflexia, absence of limb weakness is the second one. Third, same, the duration from the onset of symptom to the nadir should be 28 days, 12 hours to 28 days. Fourth is electrodiagnostic test should be normal or sensory involvement may be there, and CSF should be same, the protein should be elevated, cell should be less than 50, and the other two, conscious level should be normal and no evidence of corticospinal tract involvement. The last one is no other diagnosis should establish the present condition. This is the level 1 criteria for Miller-Fisher variant. The level 2, same, areflexia, ophthalmoplegia, ataxia, absence of the limb weakness. The third remains the same, the onset of symptom to the nadir should be around 12 hours to 28 days. The fourth is same like that, protein may or may not elevated, cells will be less than 50, and electrodiagnostic should be normal or it may show sensory abnormality. And the last two are no altered level of consciousness, corticospinal tract is not involved, and no other diagnosis should explain the cause of the Miller-Fisher variant symptoms. That is level 2 evidence. Level 3 evidences, same, ophthalmoplegia, areflexia, ataxia, absence of limb weakness. The third remains the same, from the time of onset to the duration should be between 12 hours to 28 days, and fourth won't come here, either electrodiagnostic or CSF, only clinical will come here. So, the next two will come, that is no altered level of consciousness, no corticospinal tract involvement, and the last one is no other diagnosis should explain the symptoms whatever the patient is having. This is the Brighton criteria level 3 for Miller-Fisher variant syndrome students. What is Asbury criteria for Guillain Barre syndrome? Involvement of 2 or more limb weakness, areflexia, duration of the symptoms less than 4 weeks, no other diagnosis should explain like porphyria, toxins, lead toxicity, vasculitis should not explain the cause. These 4 are required, and there are some supportive. Supportive is symmetrical motor weakness, mild sensory impairment, only mild, it should not be a major. Absence of fever, as I am telling again and again, mild sensory involvement, absence of fever. Then CSF correlating with the AIDP like albumin cytological dissociation, electrodiagnostic feature correlating with the AIDP, and facial nerve involvement is another supportive criteria. These are the supportive criteria, required and supportive criteria for Asbury criteria for Guillain Barre syndrome. What are the differential diagnosis, students? As I discussed in this case, same, transverse myelitis, one of the closed DD, diphtheria, porphyria, poliomyelitis, OP poisons, neuromuscular junction disorder like myasthenia, periodic paralysis, thallium poison, arsenic poison, OP poison. These are some of the DDs for Guillain Barre syndrome. Coming to the treatment. Treatment, each day counts, each hour counts. Clinically, if you are sure, don't delay for nerve conduction study or CSF analysis. Start the treatment. If the patient is having a mild symptoms or if the weakness has plateaued after 2 weeks, your therapy not going to do anything, not useful. Both IV immunoglobulins as well as plasmapheresis both are equally effective. Both together is not required, either of one is enough. Especially Ammon variety and Miller-Fisher variant variety, IV immunoglobulins is better given. IV immunoglobulins 2 grams per kg body weight for 5 days. Plasmapheresis 40 to 50 ml in each setting, 5 to 6 plasmapheresis settings in a 10-day period you can give. Then whenever the patient, 30% of the patients, as I told, require mechanical ventilation. Whenever they are in the ICU, you have to take care of the autonomic dysfunction what they may develop, maintain proper heart rate, blood pressure, physiotherapy, chest physiotherapy, vital capacity, deep vein thrombosis prophylaxis, early tracheostomy. These are some of the things which you have to give care. They die due to pulmonary complications, not due to the weakness. So, what is the prognosis of Guillain Barre syndrome? 85% recover like her nicely. Mortality is only less than 5%. The bad prognosis factors are old age, if they come initially with quadriparesis, involvement of the bulbar, involvement of the lower cranial nerves, and delay in start of the treatment. These are all bad prognostic factors. So, I repeat, old age, delay in initiation of the treatment, initially coming with the quadriparesis and tempo of progression is rapid, and bulbar involvement. So, the bad prognostic factors are initially coming with the quadriparesis, increased age, rapid tempo of the progression, involvement of the bulbar cranial musculature, involvement of the bulbar cranial nerves, and delay in the initiation of the treatment. These are the very bad prognostic factors in Guillain Barre syndrome. Now, let me discuss some points about CIDP and compare AADP with CIDP. CIDP, here the motor weakness or the progression will be slow over months, unlike the AADP which occur in hours to days like this. It occurs in adults compared to children, and males are more affected compared to females. CIDP, they may have a subjective sensory symptoms, and because of the remyelination and demyelination, they will have thickening of the nerves. If the weakness persists more than 9 weeks or more than 3 recurrent episodes, then it is considered as CIDP. If the weakness, tempo of the weakness in a demyelination disease progress for more than 9 weeks or 3 repeated episodes, it is CIDP. Some they will run a chronic course and some they will run a relapsing and remitting course. Some they will have pure motor weakness, some they will have even sensory ataxia. Tremor is seen in 10% of the patients, especially when they worsen or when they improve. At that time you get a tremor, which is not seen in AADP. Cranial affection is rare compared to AADP in CIDP, but ophthalmoplegia can occur. Here, what is the pathophysiology in CIDP? Contactin associated protein and neurophysin 155 are the targets here for CIDP in 10% of the patients. In 25% of the patients, it is associated with monoclonal gammopathy of unknown significance. If it is associated with neurophysin 155 or contactin associated protein, there will be a more axonal damage, sensory ataxia, and more distal muscle weakness, and the less response to immunotherapy. Monoclonal gammopathy of unknown significance, IgG and IgA kappa will be there, autoantibodies, they respond nicely. If IgM kappa is there, again they will have a more axonal degeneration, more sensory ataxia will be there, and more distal muscle weakness, and they are less responsive to the immunotherapy. Other associated conditions like lymphoma, SLE, HIV, vasculitis, amyloidosis, diabetes, you have to rule out in a CIDP. What are the diagnosis? Diagnosis is same like AADP. CSF will give a picture of alveolo-cytological dissociation. The nerve conduction study will show the same picture like F wave absent, H reflex absent, distal latencies will be prolonged, conduction block will be there, and conduction velocity will be reduced in CIDP. How do you treat a CIDP? The incidence of GBS is more compared to CIDP, but the prevalence of CIDP is more because it runs a very chronic course. They respond to glucocorticoids unlike Guillain Barre syndrome. All the three are equally effective in CIDP: IV immunoglobulins, plasmapheresis and glucocorticoids. So, glucocorticoids are not effective in AIDP students, but effective in CIDP. IV immunoglobulins, you will give the same dosage 2 grams per kg body weight for 5 days for the monthly interval for 3 months. Then once improvement occurs, then later you will increase the duration or reduce the dose like 1 gram per kg body weight. Plasmapheresis 30 to 40 ml per kg body weight. You will do 2 to 3 settings in a week, like that 6 weeks you will do. At least you have to treat for 3 months before you say one therapy is ineffective. If one mode of therapy is ineffective, then you have to switch to the other mode of therapy. Glucocorticoids you give around 60 to 80 milligrams per day for 1 to 2 months, and then you taper 10 milligram per day, 10 milligram per month, tapering, you will start tapering it. Students, the weakness in CIDP is symmetrical like in AIDP, but there is one variety known as multifocal acquired demyelinating motor sensory neuropathy, also known as Lewis-Sumner variety, where there can be asymmetrical weakness, just for your information purpose. So, glucocorticoids, plasmapheresis and IV immunoglobulins all are equally effective. They respond nicely over the years, students, CIDP, and mortality is very rare in CIDP compared to AIDP. So, this is about CIDP and AIDP and this clinical case discussion. So, you are lucky to have a very good case of AIDP. These acute cases are very difficult when we prepare the module, but we got the case and you are very lucky to have this case. And CNS, as I told students repeatedly, I am telling, very simple. Anatomy, you go either from periphery to central or central to periphery. Each level, what are the diseases if you know enough. At each level, we will discuss one case. Already we have discussed a dermatomyositis. We have discussed a myasthenia gravis, ocular myasthenia gravis. We are going to discuss peripheral neuropathy in next class, and this is anterior root, and we will discuss spinal cord also. At each level we will discuss, and so that we will try to make you CNS simple and easy.